Thank you very much. Welcome everyone to this first symposium. My name is Kamran Ikram and I'm co-chairing this session together with Daniel Bos. I'll briefly introduce myself and Daniel, and then we'll go ahead with the presentations. So again, my name is Kamran Ikram. I'm a professor of clinical neuroepidemiology working at the Erasmus Medical Center. And Daniel is an associate professor also working at the Erasmus Medical Center. I can't see Daniel here. He is here. Yes, he is. Yeah, maybe you can wave your hand or say something briefly.
Yes, I'm here. Thank you, Gama.
Yeah. Okay, perfect. So we go ahead with the session. In the program, it said actually 4 presentations and then 2 abstracts, but actually we have 3 presentations. Yuan Ma couldn't make it. So we have 3 presentations, and I guess we'll take questions after each presentation. So a presentation 12 minutes, then we have 5 to 6 minutes for questions. And that's how I suggest we proceed. So Daniel, I'll ask you to present the first speaker.
Yes, thank you very much. And also on my behalf, thank you for being here in this great session. And I would like to start with introducing the first speaker. That is Dr. Frank Wolters. He is a senior scientist at the Department of Epidemiology and the Department of Radiology of the Erasmus Medical Center. And he is an expert in the role of vascular disease in cognition and dementia. And in that perspective, I would like to give him the floor to say something more about his topic on orthostatic hypotension and heart failure and the risk of dementia. Frank, floor is yours.
Thank you very much, Daniel. Thanks for the invitation to speak here. It's great to see that we're united here in such great numbers in this session. A lot can be said about blood pressure variability and changes in blood pressure. I'll focus today on the changes, the postural changes in blood pressure and what the implications are for cognitive impairment and dementia across different etiologies. And in a bit more particular, I'll approach it from approach the question like, is this due to vascular risk, or could it also be a prodromal sign? And well, as you often see with many of these questions, the answer is a bit twofold depending on perspective. But at least I hope to give you some more grasp on what underlies this and what are the implications for further research and also clinical practice. Next slide, please. So orthostatic hypertension, the postural changes in blood pressure upon standing is highly prevalent in the elderly population. If you look in the very elderly from the age 80 onwards, it's about 1 in 3 individuals in the community who can be diagnosed with this. The graph you see on the top right is from the population-based Rotterdam study. So these are people in the community without prior indication for measurement, in whom we've seen this in very high numbers, and arguably in many clinical populations will be slightly higher. So we've known for a long time that these postural blood pressure changes are associated with subclinical vascular disease and mortality that ranges across the spectrum of different manifestations of cardiovascular disease, say stroke or myocardial infarction, heart failure, etc. And I've shown you here the table is from the results from population-based study in the US, the ERIC study, where actually very elegantly shown a comparison of these different outcomes in the same population, showing that the presence of orthostatic hypertension basically increases the risk of a broad range of vascular diseases, illustrating that, if anything, this is also a marker of wider vascular and subclinical vascular damage. But that's not all. Next slide, please. Because it's more than that, arguably, and it starts all with the definition, of course, of the orthostatic hypertension. And most guidelines sets a systolic drop, as you will know, of more than 20 millimeters mercury and diastolic of more than 10. It should be noted that you rarely see the diastolic blood pressure drops without the systolic drops, and that this is, well, of course, often accompanied by dizziness or other symptoms upon standing up, but can very well also be asymptomatic. If we get one further click, please. There should be an image here also. Yep. This definition it's quite broad. It can altogether capture a variety of different manifestations of orthostatic blood pressure drops and their recovery. And I think this image on the right illustrates it nicely. It's got Vera van Wijnen in Groningen, shown in hypertension. And it shows on the how both the periodic changes in the drop as well as the time to recovery can change between individuals. Whereas in the top row, you see that the blood pressure, the normal actually blood pressure drops in a healthy 26-year-old woman who has a bit of blood pressure drop, both systolic and diastolic, with a compensatory increase in heart rate, which is recovered well, basically within 30 seconds from standing up. There's the below a 14-year-old boy, no clinical diagnosis, but where the drop is a bit more profound. So it can be, but still you can see a quick recovery with some increase in heart rates. And then if we move on to the 67-year-old man with hypertension, as we might see in clinic typically, is with a relatively early blood pressure drop, again, systolic as well as diastolic, which is prolonged over time. So the recovery takes quite a bit longer than we would see in normal physiological circumstances. And also you can appreciate here from the bottom row in that individual that the increase in heart rate is less profound. So there's some degree of gonotropic incompetence, a failure really to compensate for this drop in blood pressure by increasing heart rate. We see a slightly different pattern though in another 76-year-old man who also has clinical orthostatic hypertension, but where we see that the blood pressure drop, although similar to the prior individual, here is sustained for a longer time. So the recovery doesn't come on as quickly, and again the increase in heart rate here is virtually absent. And this could be indicative of autonomic failure. So within this broad definition of orthostatic hypertension, you can see that there is different manifestations really, which may indicate different underlying processes, and I'll get back to that a little bit later. We can have the next slide, please. To answer the main question, really, it's already evident from looking at different types of dementia that orthostatic hypertension is not a feature that arises solely in vascular disease. We'll see it with vascular dementia, very common, but it's also very common with Lewy body dementia, Parkinson's disease, where the autonomic disturbances are of importance, and with Alzheimer's disease similarly. Also in patients who present to memory clinics, if we look at progression from MCI to dementia, we see this is of relevance, and also in patients with AD, we see that this prolonged dipping, so the slow recovery of the blood pressure is associated with clinical progression of AD symptoms as visualized on the right by work from Jürgen Glasenschop in Nijmegen. So what are the underlying brain correlates then? Well, these correspond to what we see in the clinical phenotypes, in the sense that in patients with Parkinson's disease or Lewy body dementia, the orthostatic hypertension is related to the degree of atrophy, but not so much to the white matter hyperintensities. Whereas if we look at the broader phenotype of individuals without neurodegenerative disease, we do generally see that markers of small vessel disease are also correlated to the presence of orthostatic hypertension, in addition to atrophy. So again, suggesting that both here are important. And should be noted that many of these studies used to commonly uphold a definition of orthostatic blood pressure changes, which doesn't always necessarily allow to distinguish the different types of postural hypertension. Get to the next slide, please. So moving on basically from the clinical population to a more general population, what does orthostatic hypertension mean for cognitively healthy individuals? So I've shown you the prevalence also in these younger age groups, and those without cognitive impairment. The prevalence of orthostatic hypertension is high. And here we see an overview of the different studies. These are longitudinal, generally population-based studies who've examined this association with dementia risk over time, with follow-ups ranging from, say, 5 years to about 20 years and more. So covering a wide follow-up range also beyond the early prodromal phase of dementia. And that shows that overall there is an increase in dementia risk associated with orthostatic hypertension, which varies a bit between studies, partly I guess due to differences in methodology, but in general, in most of these studies show that there is some degree of increased risk of dementia over time. In studies have looked at that this wasn't entirely mediated by clinical stroke, so suggesting other processes are also involved. And interestingly, it occurs both with and without symptoms. So many of these orthostatic blood pressure drops can be asymptomatic. So also these asymptomatic drops can be related to symptom onset. And similarly, a dizziness without a clearly defined drop after 3 minutes may also be. So again, this may be related to the definition of orthostatic hypertension, not capturing all the drops properly if there's been a recovery within 3 minutes already. Next slide, please. So is that then more than simply a blood pressure drop? Well, given the limitations in that sense of the definition, capturing a lot of a variety of effects, there may well be. We've examined this, for instance, in the Rotterdam study. We've let go of the dichotomous definition and looked at more continuously at the coefficient of variation of blood pressure after postural change, and then we saw that even in individuals without the formal definition of orthostatic hypertension, there is an association with this variability with dementia onset in subsequent years. So this is variability measured in relation to postural change. There may be some overlap there, but I think it requires further examination to see whether that's similar to say beat-to-beat variability and complexity measures that we know are also associated with dementia risk, independent of postural change. I've already touched upon the heart rate earlier. The chronotropic incompetence is an important marker, as we also saw in the Rotterdam study. Here on the bottom right, to show you the figure which stratifies the risk of orthostatic hypertension by degree of heart rate increase. And there you can see that the individuals with the least heart rate increase, at least or no increase in heart rate, had the highest risk of dementia associated with orthostatic hypertension. And well, this could really point in different directions, really, because first of all, it's related to the heart rate increase is related to autonomic nervous system dysfunction, but it could also be related to the blood pressure drops itself, which are insufficiently compensated. Next slide, please. So in addition to like the underlying pathology that might affect the autonomic nervous system function, it could also relate to blood flow regulation. As we know from prior studies that orthostatic hypertension itself is related to baroreceptor reflex, to arterial stiffness, and these things combined could also, of course, make any blood pressure drop have more of an effect on transient hypoperfusion of the brain. And that could give rise to, say, multiple hit hypothesis, where the presence of orthostatic hypertension itself may not always be detrimental if there is proper mechanisms to compensate the blood pressure drop fall, which could either be increases in heart rate, but could also be impaired in case of heart failure, where flow is already disturbed, and there may be less of a compensatory response from cardiac contractility. Similarly, vasoreactivity could also account for that. To see we have little support, I think a few of the analysis of incident dementia after orthostatic hypertension have looked at it specifically in these patient groups. We saw, for instance, again, in a community study in Rotterdam, that if we do stratify by heart failure, and the numbers quickly become very slow, but seem to be a bit higher risk associated with orthostatic hypertension in the presence of heart failure. And I think studying the postural blood pressure changes in the context of this multimorbidity and various blood flow regulation mechanisms could improve important insight. It doesn't go just in that direction, because we also see that vice versa. Once someone has orthostatic hypertension, it's a risk factor for developing heart failure also. So these two things can commonly coincide. Again, this I think illustrates that it could be in part related to an autonomic nervous system failure, but it could also reflect the underlying vascular pathology in relation to concomitant artery disease, hypertension, of course, and the myocardial contractility. It does I think make management more challenging, because some of the treatment options, in the sense of making sure that blood pressure is high enough, may be a bit problematic in patients with heart failure there. Next slide, please. Yeah, so that brings us to treatment. I mean, you will be aware of most of the non-pharmacological interventions that are there to increase the tone of the vascular, but make sure that there's enough fluid intake. There's a few pharmacological interventions, not all registered also for use of orthostatic hypertension, and not all feasible in patients with heart disease, something to take into account. I do want to zoom in a little bit more on the last bullet point, like the withdrawal of cardiovascular medication, because both these types of medications are known to contribute to orthostatic hypertension, but to what extent should we be withdrawing this medication? They might be concerned, or starting this cardiovascular medication, be concerned about the incidence of orthostatic hypertension and the consequences on the brain. So we can have the next slide, please. So are the antihypertensive medications in people with orthostatic hypertension safe to start? I think a very relevant question in terms of brain health. I think we've seen in blood pressure lowering trials that intensive blood pressure lowering does not increase the incidence of orthostatic hypertension. So at least it's reassuring in the sense that that the problem doesn't seem to be magnified by lowering blood pressure for other indications. And that also applies to some extent as far as there's evidence for patients with MCI and AD, at least for calcium channel blockers, that blood pressure lowering also does not seem to increase the incidence of orthostatic hypertension in the NILVET trial. Then looking at the initiation of blood pressure lowering treatment in patients with orthostatic hypertension, I've summarized here the results of the SPRINT trial, SPRINT-MIND. And for various disease outcomes, either dementia, MCI, or dementia, or changes in white matter hyperintensities on MRI, these analyses have been stratified for orthostatic hypertension. And what you see across the board is that there is no significant effect modification by orthostatic hypertension for the treatment effects. So the intensive blood pressure lowering was associated with similar effects on either of these outcomes, so either clinical dementia, MCI dementia, or progression of white matter hyperintensities in those with and without orthostatic hypertension. So suggesting that the presence of orthostatic hypertension should not necessarily be a reason not to lower blood pressure in view of these outcomes. Next slide, please. Was there? Yeah, so, and then the other question is, like, with antihypertensive medication, is it better to discontinue it once someone has orthostatic hypertension? Well, there's I think limited evidence on modification of blood pressure in those with orthostatic hypertension. But what we do know from the Dementia trial, in which individuals with MCI blood pressure was stopped, is that blood pressure treatment was stopped, is that we do know in elderly patients without cardiovascular disease that seizure or withdrawal of medication might be beneficial, at least in recovery of orthostatic hypertension. If that differs per blood pressure lowering drug class, we don't know, and I think we need more evidence for that. And we also not sure, and I think it's important to realize that this is individuals without cardiovascular disease, and I think the decision to either or not withdraw this medication is obviously taken in context of risk of ischemic cardiovascular disease. Next one, please. Yeah, so to round up, orthostatic hypertension is highly prevalent in the elderly population and increases dementia risk. It's also common in other dementias, so likely due to either autonomic failure or vascular disease, and the different patterns in orthostatic hypertension. Change may indicate different mechanisms which could help to unravel these mechanisms and their best treatment options. And I've spoken to you about the treatments. So next slide, please. Yeah, so with that, I want to thank all the participants of the studies, both in Rotterdam study, and fellow collaborators, and maybe make most of the opportunity here to highlight that within the Heart Brain Consortium, we'll be organizing a symposium on the 6th of October on heart brain health and the role of the heart brain axis and vascular cognitive impairment. So I would encourage you all, if you're interested, feel free to subscribe. It will be a free online symposium and organized in Utrecht in the Netherlands. Thank you.
Thank you very much, Frank. Very nice overview and very well presented. So we have two questions in the chat. I would like to start with one of them. We have time for a couple of questions. So the first question pertains to formally quantifying cerebrovascular reactivity in patients with orthostatic hypotension. Has that ever been done? And may that explain some of the cognitive changes when not in context of MSA, for example?
Yeah, it's an excellent question. I think studies could really benefit from like phenotyping different types of autoregulatory mechanisms in the same patients. There have been some studies who looked at this in part, but I think they could definitely use more evidence to show whether or not these two interact in cognitive decline and dementia, and then mainly in the stage before cognitive decline, because I think those studies in particular are rare. So how do things work in individuals in a slightly pre-symptomatic state maybe, and showing the interactions with different comorbidities and eventually disease onset. So I think yes, and I think these things could work. I think that there's different mechanisms to quantify vascular activity, of course, either ASL, Diamox, or using transcranial Doppler. I think it will be feasible, and mostly feasible in research setting, of course. In clinical setting, maybe a bit more difficult. But to relate that, for instance, to infrared, near-infrared spectroscopy, I think would be very interesting.
Very nice. And one additional question that also I personally had is there anything known about the duration of orthostatic hypotension? So is it some people may have it already for years, some people have it shorter. Is there something known about the, say again, duration and the risk of subsequent dementia or disease?
Yeah, I'm not aware of the studies who've looked at that particular question. I do remember of one study that looked at like the incidence of orthostatic hypertension also in the community in relation to dementia risk. And then it was also evident that even people who developed orthostatic hypertension during follow-up visits were also at increased risk of developing dementia. So that suggests that it doesn't necessarily need to be a very long exposure. It can also be like a history of hypertension for just merely a few years that could explain part of this relation. And I think that is, to come back to the original question, in part because it autonomic nervous system dysfunction that can manifest itself as orthostatic hypertension. So yeah, so I think there may be two different mechanisms, one more in the short term and one on a more prolonged risk factor exposure level.
All right, thank you very much. Are there any additional questions that people want to ask at this moment? I don't see any virtual hands. Okay, then I would like to carry over to Kamran for the next.
Yes, thank you. So thank you, Frank, for a wonderful presentation. So the next speaker, that is Saima Hilal. She is from the National University of Singapore. She is an assistant professor there, and she's going to talk about cardiac dysfunction and cognition and dementia.
Thanks, Kamran, for the introduction.
Yes, I see that there are some issues with your slides. At least they have trouble putting them up. So we may have to wait. Well, other option is that you share your own screen. Is that a possibility?
So let me try. That's possible. So they have to enable that because it's being disabled.
Oh, okay. Well, they say give 1 minute. So
okay.
Yeah. Okay. The slides are with them, so they're trying to put them up now. Yeah, sorry for this inconvenience.
No worries.
Why is it not opening? Oh, because yeah.
Yes, we now see Raj sharing a screen. Okay, yes, we're there.
Hey.
Okay, perfect. So Saima, it's up to you.
Thanks, Kamran, again, and thank you for the VESCO committee for giving me this opportunity to speak on cardiac dysfunction. So I've also added in the neuroimaging part to this, as well as cognition. Next slide, please. So I guess the audience is already familiar with the heart-brain axis. So briefly, hemodynamic balance is one of the crucial factor in the heart-brain axis that's required to maintain the structural and the functional integrity of the brain and cognitive functioning. And it has been hypothesized that the hemodynamic status of the heart and brain is an important but an underestimated cause of vascular cognitive impairment. Therefore, it is important to understand really the extent of hemodynamic changes that contribute to VCI and what kind of mechanisms underlie such process. Next slide, please. So I guess you're already familiar with this famous quotation by Thomas Sydenham that a man is as old as his arteries, which already give us the notion that there might be an intimate relationship between the brain and the heart. Next slide. So with this relationship in mind, we can actually intuitively state this, that a man's brain is as old as his heart. Next. So now in general, the pathologies in the heart-brain axis usually act together to actually produce the accelerated brain aging. Next. And it has been shown that cardiac dysfunction not only gives rise to structural changes in the brain, but it also increases the risk of mild cognitive impairment and dementia to as high as about 80%. Next. So I guess in terms of the biomarkers of vascular damage, most of the subclinical vascular brain injuries are typically detectable via brain MRI or the detailed neuropsychological assessment. But one of the biggest limitation is that for a large scale screening, such tests are not very practical in routine clinical test settings. And that's where most of the cost-effective, rapid, and minimally invasive biomarkers are needed as initial screening tool. Next. And that is where some of these important cardiac biomarkers come into play. So I guess you're familiar with the N-terminal protein brain natriuretic peptide, which is briefly called as NT-proBNP. And this particular hormone is typically released when the cardiac myocytes are distended, and they produce the BNP prohormone. So this proBNP typically splits into the NT-proBNP and BNP. So the biological effects of the BNP typically includes diuresis, vasodilatation, inhibition of renin and aldosterone production, as well as of cardiac and vascular myocyte growth. Next. So the NT-proBNP in general is a non-active form compared to the BNP, and it has a short half-life. And it is reported to be linked to coronary heart disease, stroke, as well as subclinical brain injury. Next. The other biomarker that has also gained attention besides the BNP is the high sensitivity troponin T. And the TNT is essentially a marker for myocardial injury and potentially vulnerable coronary atherosclerotic plaques. So there have been suggestions that the presence of mixed plaque and irreversible ischemia are significantly and independently associated with the TNT levels. So the increased TNT may be a result of provocable ischemia, which is basically present in both presence and absence of significant coronary disease. And it is essentially secondary to the plaque rupture with distal embolization. Next. So besides the BNP and TNT, another marker that has gained a lot of interest in the literature is the growth differentiation factor 15. And the GDF15 is also known as the macrophage inhibitory cytokine 1. So GDF15 also has an anti-inflammatory pro-apoptotic stress response cytokine, which belongs to the transforming growth factor beta superfamily. It is typically elevated in injury to brain, liver, and heart. And it is also reported to be linked to the prediction of CVD, heart failure, worse cognitive outcome, and dementia. Next slide. So far, we have assessed all the 3 cardiac biomarkers in a memory clinic population, and we have also looked into its association with cognitive impairment as well as some of the neuroimaging markers. Next. So what you can appreciate here is this, that the higher levels of proBNP is essentially linked to the higher odds of having dementia. Next. And with respect to the higher levels of TNT, the higher tertiles of TNT was essentially linked with cognitive impairment as well as with dementia. And you can see that there's an increasing odds from CIND to dementia in this analysis. Next. So we went on further to also explore the link between the BNP TNT as well as the cortical microinfarcts that were graded on the 3 Tesla MRI scans. And interestingly, what we have seen here is that the subclinical cardiac biomarkers, which is reflected by the high levels of BNP and TNT, were related to the increasing number of microinfarcts on the scan. Next. And if we look into the clinical cardiac diseases, which is reflected by the atrial fibrillation, ischemic heart disease, and congestive heart failure, we can see that these diseases were again independently linked with the microinfarcts on the scan. Next. And if we exclude individuals who have clinically manifest cardiac diseases, we can see that the high levels of BNP and the TNT were again independently linked with the microinfarcts on the scan. Okay, next. So we went on further and looked into the effects of GDF15 and its association with cerebrovascular disease and dementia in the same memory clinic population. And interestingly, we can see here is that the higher levels of GDF15 is related to the diagnosis of AD. Next. And then at the same time, if we stratify the population by the presence and absence of cerebrovascular disease, we can see that the higher totals of GDF15 was related to cognitive impairment as well as with AD. Next. Can we move on next? And if we look into the different components of the cerebrovascular disease markers, we can see that GDF15 was related to increasing severity of white matter hyperintensities. However, no association was observed with the cortical infarcts and lacunes. Next. So besides the cross-section analysis, we have also explored the effects of cardiac biomarkers with cognitive decline, cerebrovascular disease, as well as clinical events. And interestingly, what we have observed here is that the higher levels of BNP, TNT, as well as GDF15 were related to the worst performance on memory domain at all years from year 1, year 2, and year 3. Next. And if we specifically look into the rest of the domains, we can see that the higher levels of TNT were more significantly linked with the worst performance on global cognition, executive function, as well as visual motor speed. And all these associations actually survived the multiple testing as well as correction for most of the covariates. Next. So we also explored the association of cardiac biomarkers with the clinical outcomes. So with the clinical outcomes, we have a collection of vascular events, which include either TIA, stroke, or the cardiac events, as well as mortality. And we can see that the higher levels of BNP and TNT were associated with incident vascular events. And separately, BNP and GDF15 were related to an increased risk of mortality. Next. So another marker that we have been quite interested in exploring in this memory clinic population, and which is essentially measured on the ECG, is the P-wave terminal force in lead V1. And this PTF-V1 is essentially defined as the absolute value of the depth of the downward deflection of the P wave, which is captured on the lead V1 multiplied by its duration. And elevated PTF-V1 is typically defined as the value which is greater than 4,000 microvolts multiplied in milliseconds. And the PTF-V1 is also considered one of the important markers for left atrial abnormalities, such as fibrosing dilatation and elevated filling pressure. Next. So in the memory clinic, where we looked into the PTF-V1 grading in the ECGs, what you can appreciate here is this, that besides the cardiac risk factors, even the cardiac diseases themselves were present in higher numbers among individuals who had elevated PTF-V1. And if we look into the different etiologies of cognitive impairment, specifically for vascular dementia and vascular cognitive impairment, low dementia, we again see that the elevated PTF-V1 with values more than 4,000 apparently had a higher prevalence of the VCI for the vascular dementia as well as the VCI-NT. Next. So we went on further and looked into the association between the PTF-V1 and the cerebral small vessel disease. And what you can appreciate here is this, that the increasing severity of lacunes, microbleeds, as well as the microinfarcts was indeed associated with the elevated levels of PTF-V1. But if we do the P for trend test, then this was specifically observed for the CMV. We can also see a linear association between the PTF-V1 values as well as the increasing severity of white matter hyperintensities. Next, And if we go into the region-specific microbleeds, we can see that the strictly deep microbleeds as well as the mixed CMBs had the elevated PTFV1 values compared to the other groups. And this was in comparison with the no CMBs on the scan. Next. In terms of the post hoc analysis, we also explored the PTFV1 with the clinical diagnosis, and we can see that the vascular dementia was essentially different from the Alzheimer's disease group compared to the rest of the groups. Next. So this is one of the last markers that I'm going to speak. So this is on the left atrial straining. And the left atrial straining is actually a reflection of the atrial dysfunction. And this particular marker is essentially graded on the echocardiography during the cardiac cycle. So it has essentially three components. One is the reservoir strain. The second is a conduit strain, and the third is a contractile strain. So reservoir strain is typically measured during the positive atrial strain during the systole in the reservoir phase. For the conduit strain, it is measured during the decreased atrial strain with negative deflection upon opening of the mitral valve. For the contractile strain, it is a second negative deflection due to the atrial systole. Next. So we went further and looked into the effects of the left atrial straining with the cerebral small vessel disease markers. And you can see that the left atrium reservoir strain as well as the conduit strain were significantly associated with lacunes, white matter hyperintensities, as well as the cerebral microbleeds. And all these effects were basically significant even after correcting for the cardiovascular risk factors as well as the presence of heart disease. Next. And if we look into the association between the left atrial straining and the clinical diagnosis, again, the reservoir and the conduit strains were associated with the increasing odds of dementia as well as for vascular cognitive impairment. The strengths were basically, the effects were much more significant for vascular cognitive impairment compared to dementia. Next. So in summary, the higher levels of cardiac biomarkers are associated with dementia, cognitive decline, incident MRI lesions, and incident clinical events. The PTFV1 and the left atrial straining are related to cerebral small vessel disease, dementia, and the vascular type of cognitive impairment. And most of these associations in general indicate the mechanistic pathways to stroke and vascular brain injury, which would be amenable to future therapeutic targeting. Next. So I would like to thank all the investigators and the collaborators who have joined forces with us to make sure that all these projects are publishable. So thank you very much for the efforts and also for your attention.
Yes, thank you very much, Saima, for an excellent presentation. So if there are any questions, then either raise your hand or write something in the chat, then we can discuss those. We have a couple of minutes. We're trying to catch up some time. We started a little bit later, I guess, and then we had some issues. So Saima, could you explain a little bit on the mechanisms you think? How do you link these markers, especially these novel markers on the EKG? What would be the mechanism? Of course, these markers are specifically cardial related. So how do you think that this links to the associations you find with MRI and with cognition?
So in terms of the PTFV1 and the left atrial dysfunction, I mean, as they are reflecting the left atrial myocardiopathy, in general, the mechanisms would be either the cardioembolism or if not some microangiopathies. There are also suggestions that these biomarkers are reflecting some underlying potential thrombopathologies, which probably give rise to, these the brain pathology as well as the vascular dementia. Yeah.
So did you also look specifically at subtypes of strokes or MRI lesions?
So for the subtypes of a stroke, unfortunately, the numbers were not large because in general, majority of the people have ischemic stroke and not really much in terms of the hemorrhagic. For the subtypes of MRI, I mean, I did show that, I mean, there was more specific association, let's say with the microbleeds or if not with lacunes and white matter hyperintensity. So this is what we have observed so far for the MRI lesions.
Okay, perfect. Yeah. Thank you. I don't see any other questions, and I guess in view of the time, we should carry on to the third presentation. So Saima, thank you very much for your clear presentation. Thanks.
Thanks, Kamran. Thank you.
Okay, Daniel, you can take over.
Yes, thank you. And thank you also on behalf of me, Saima. Okay, so the next speaker is Dr. Zhenyu Zhang. She is a professor at the Department of Cardiovascular Epidemiology and Cardiovascular Sciences at KU Leuven, and an expert in the field of cardiac biomarkers. And in light of this session, very nice to have you here, Zhenyu. So please let us know your view on proteomics for prevention of diastolic heart failure. Thank you.
Okay, thank you very much for the kind invitation, Daniel, and also for the very nice introduction. So today I'd like to present some of the work from our group. And the title today is the proteomics for the prevention of diastolic heart failure, which is also known as HFpEF. Next slide, please. So because now there are no easily applicable screening tool for the early detection of asymptomatic left ventricle diastolic dysfunction, and most of the patients with left ventricle diastolic dysfunction was detected in the hospital, and most of them already have very severe symptoms. So, but the prevalence of the asymptomatic left ventricle diastolic dysfunction is as high as 25% in different populations, and with a 10% risk of progression over 5 years. And nowadays we have some new drugs which is very efficient in treatment of heart failure. I think this creates a specific window of opportunity for the treatment of asymptomatic left ventricle diastolic dysfunction. That's why we would like to conduct a clinical trial, we will establish the diagnostic accuracy of a new marker which we established before in a case control study and validated in a general population, so that we want to validate in a randomized clinical trial in the next step. And before the start of this randomized clinical trial, actually there are already studies. For instance, the priority trial already assessed the efficacy and the diagnostic and prognostic efficacy of another proteomics marker, which called CKD273 for the risk stratification in type 2 diabetes. So this also gave us some hope that maybe this project will also find some interesting findings. Next, please. For the assessment of diastolic left ventricle function, we use the transmitral blood flow and mitral annular velocities. So here I would like to remind you about E prime and E over E prime. So E prime is the mitral annular velocity measured at during early diastole, and the E over E prime was the ratio between the transmitral blood flow versus mitral annular velocity during early diastole. Because E prime is a measure for the impact for the relaxation, and the lower level of E prime is indicate impaired relaxation. And high feeling pressure patients mostly have a high E over E prime ratio. So these two parameters are very important for the understanding of the following results. Next, please. For the measurement of proteomics, we use the capillary electrophoresis coupled with mass spectrometry. So what needed is just 2 to 5 milliliters of urine in the morning, and then we will get the result for after 2 days for the proteomics biomarker. Next one, please. Here shows the, so how we generate this biomarker. First, we conduct a case control study in 36 cases with left ventricle diastolic dysfunction and 36 healthy controls. If you look at panel A here, this is the urinary proteomic pattern from left ventricle diastolic dysfunction patient. And panel B shows the urinary proteomic pattern of healthy controls. If you compare these two different patterns, you will see there are 85 urinary peptides, which was differently expressed in these two kind of patients. Well, in this in patient and controls, so that we summarize the information of these 85 urinary peptides together, use support vector machine. So each patient get a score, which we call it HF1. So this is from the result from a case control study, and the area under the curve for the diagnostic of left ventricle diastolic dysfunction is about 86%. So the next step is to move to the general population, because the result from a case control study cannot be generalized to the general population. So the next step, we validate whether this marker from case control study could also be associated with left ventricle diastolic dysfunction in the general population. We assessed the association in a population in North Belgium. Around 3,000 participants was recruited during as from 1985 until recently. But in this study, we include a subgroup of participants, 745 of them. As you can see here, shows the distribution of HF1. So those ones with lower value indicate normal function, and those ones with higher value indicate left ventricle diastolic dysfunction. As you can see, the distribution is, well, more or less normal. Next, please. And here shows the adjusted association of the echo parameters with HF1 in 745 participants, which are general population. As you can see, after adjustment for core variables, once the increment in HF1 was associated with a lower E prime, which indicative of impaired relaxation, and also associated with higher E over E prime, which is a parameter for elevated feeling pressure. And this is the continuous study, but for the categorical study, which I didn't show the result here, it also shows that HF1 was associated with left ventricle diastolic dysfunction in this cross-sectional study. Next, please. So in the next step, we would like to see, okay, what about the prognostic value of this marker, which we already validated in the general population? So we measured HF1 at baseline, and then we assessed left ventricle function after 5 years. And we would like to see whether the baseline HF1 value could predict left ventricle diastolic dysfunction after 5 years. If you look at the panel on your left, so the x-axis shows age, and the y-axis is the probability of left ventricle diastolic dysfunction. And the white dots are men and the red dots are women, so that you can see the probability of left ventricle diastolic dysfunction increased with HF1, especially after, so you can see the probability of left ventricle diastolic dysfunction increased with age, especially after the age of 50. You could see the probability increased dramatically. And next step, we would like to see whether after the adjustment, the association between left ventricle diastolic dysfunction and HF1 still exists. So we first put HF1 into the model, and you can see the odds ratio is about 2. And then we put sex into the model, so you see the association didn't change significantly. But then we put age into the model, you could see the effect size actually decreased a little bit. After all the adjustments, HF1 still associated with left ventricle diastolic dysfunction measured after 5 years. So now we can see, okay, HF1 has the diagnostic value as well as prognostic value. But we know the incidence of left ventricle diastolic dysfunction is a soft endpoint. What about the cardiovascular endpoint? Next, please. Next slide. So here shows the incidence of cardiovascular and cardiac events by third of HF1 distribution. As you can see, the x-axis is HF1, and the y-axis is the event per 1,000 person years. And the right dot represents cardiac events, and yellow square, they are the cardiovascular events. As you can see, the event rate increase across HF1 tertiles for both cardiovascular and cardiac events. So next, please. So we propose for the clinical application of HF1. For instance, in the patient with risk factors like hypertension, or those ones with an age of 50 or higher, or those ones with obesity. And in this cohort, there are 167 with all these 3 risk factors. And we propose to measure HF1 in this subgroup of population. And then we calculate the optimized threshold, which is minus 0.35. So if HF1 is lower than this value, then we propose to manage risk factor for another 5 years. But if HF1 is above the threshold, then if a repeated result also be consistent with this value, then we really would recommend the patient to have an echocardiography in the hospital. Next slide, please. But before the clinical application of any new markers, randomized clinical trial is much needed. So what we would like to propose is a clinical trial, but combined with an observational study. So we would like to screen the patient in the general population. Those ones with age of 50 or higher, or at least three more risk factors. And this patient will be given the test of HF1. And for the low risk patient, they will be assigned to the observational care, or they will be the control arm if they have a higher risk with an HF1 value higher than the threshold. So that when we compare these two groups, we will see the diagnostic and the prognostic accuracy. And then another group is a patient with high risk, so that they will be assigned to the intervention group. So we will use the Eurocare and the intervention. So the intervention, what I mean is new drugs that comes out to the market recently. So please press the button, because this is okay. So the primary endpoint is the echo measure the left ventricle diastolic dysfunction, and the sample size calculation shows that 580 participants per arm is needed. Okay, next. So for the potential drugs, for instance, the ARA or ARNI or SGLT2 inhibitors, which I think this is a very interesting agent, because now, just recently, European Society of Cardiology just reported a new clinical trial. So that this trial shows for the first time, so this SGLT2 inhibitor is successful in HFpEF patients. Well, in patients with diastolic heart failure. So it shows it decreased the risk of re-hospitalization and decreased the risk of cardiovascular events and cardiac events. So I think this is a very promising inhibitor, but the results is based on the symptomatic diastolic heart failure patients. So in our trial, we would like to test this hypothesis in asymptomatic patients with left ventricle diastolic dysfunction. So that's this is the end of my presentation. And if you have any questions, please feel free to ask. And thank you very much for your attention.
Thank you very much for this novel, I think, at least for me, at least for a lot of other people, novel insight into a novel marker of diastolic dysfunction. And of course, if there are any questions, please raise a hand or type it in the chat. In the meantime, I was also going to ask you whether you think that this could also ultimately, we of course, we know diastolic dysfunction is linked to mild cognitive impairment and changes on cerebral MRI, like white matter lesions, lacunes. Would you think that this marker, for example, HF1, would also be linked to these endpoints? Is that also something you are pursuing in your current or next studies?
Yeah, I think that's a very interesting topic for us as well. So in our population, we also have the outcome of dementia and the stroke and all these endpoints. And the next step, we will certainly invest the association between this new marker and the dementia stroke and for this endpoint. And that's a very interesting topic. Thank you.
Yes, and also especially in light of the treatments you refer to, that could be a very interesting topic or target to intervene upon. I see no questions in the chat. Also, in light of time, I think we have two more presentations. I think we proceed to the next one. Thank you very much, Sen Yuzang, for this presentation. And I give the word back to Cameron.
Yes, thank you. So I guess we have now two shorter talks from the abstract selected. And the first one is by Simin Mahanrat. I hope I pronounce your name properly, and if not, then please correct me. Simin is from the Department of Neurology from Northwestern University, the Feinberg School of Medicine, and she will be talking about blood pressure variability, cognitive decline, and dementia. Please go ahead.
Thank you. Thanks, Dr. Ikram, for the introduction. Yes, my name is Simin Mahinrad, and I'll be talking about the results of our recent work on blood pressure variability, cognitive decline, and incident dementia. Next slide, please. Yes, so just briefly, we know that hypertension, especially if measured in midlife, is associated with increased risk of cognitive decline and late life dementia. But beyond static measures of blood pressure, higher blood pressure variability and also excessive variability in blood pressure has been also shown to be linked to cognitive decline, features of cerebral small vessel disease, such as white matter hyperintensity, and also increased risk of stroke in older adults. But the link between blood pressure variability and dementia subtypes, especially mild cognitive impairment and Alzheimer's disease in community during older adults, remains unclear. Next slide, please. So in this study, we aim to address this knowledge gap and look into the relation between visit-to-visit variability in blood pressure, cognitive decline, and incident dementia, specifically Alzheimer's disease and mild cognitive impairment in a large community-based cohort of older individuals. Next slide, please. So for our analysis, we used data from 3 ongoing community-based cohorts that are based at Rush Alzheimer's Disease Center in Chicago. So these cohorts recruited individuals from across the US. And the cohorts are religious order study, a memory and aging project, and minority aging research study. As you can see, the time of enrollment in this cohort and the ROS cohort started enrollment in 1994 and has up to 25 years of follow-up data. MAP cohort started enrollment in 1997 with up to 21 years of follow-up, and MARS cohort has up to 17 years of follow-up data, which primarily includes African American individuals. And the median follow-up for these cohorts was 10 years. Next slide, please. Here you can see the enrollment in each of these cohorts, and with the cumulative enrollment of around more than 4,000 participants up to 2021. Next slide, please. So for this analysis, we pulled data from this 3 cohort, which resulted in around 4,400 participants. And after excluding those who were younger than 65 years of age or who didn't have enough follow-up data, especially if they had less than 3 blood pressure measurements, and also if they had a clinical diagnosis of dementia or MCI at baseline, we ended up with around 2,400 participants, with 46% of them from the MAP cohort. Next slide, please. So a little bit about our methods. Primary exposure was blood pressure variability, which was assessed at each annual visit over the follow-up. The median number of blood pressure assessment was 9. We assessed blood pressure variability using coefficient of variance. Cognitive function also was assessed at each annual visit using a computer-based 19 cognitive tests, and use these scores to drive different domains of cognition, especially global cognition, working memory, episodic memory, and processing speed. Also, dementia was ascertained at each annual follow-up visit using NIN-CDS ADRD criteria with using computer cognitive tests, and also judgment from a neuropsychologist and a clinician. For statistical analysis, we use multivariable models to adjust for potential confounders, especially sociodemographics, vascular risk factors, vascular diseases, and also antihypertensive medication use and other medications. Next slide, please. So here you can see the baseline characteristics of the included participants in this cohort. The mean age at baseline was about 76. 76% of them were female, and more than half of them had a history of hypertension at baseline. History of stroke at baseline was about 6%, and 65% of the participants were on antihypertensive medications. Next slide, please. So these are the main results: blood pressure variability in relation to a change in cognitive function. Here we use linear mixed effect models, and in the upper table you can see the beta coefficient and standard errors from fully adjusted models. And as you can see, the change in the higher systolic and diastolic blood pressure variability, both of them were associated with a steeper decline in all domains of cognitive function that was assessed in this study. And in the below graphs, you can see the predicted global cognition plotted against time. And you can see that those who were in the highest tertile of systolic and diastolic blood pressure variability had a steeper decline in global cognition compared to those who were in the lowest tertile of blood pressure variability. Next slide, please. And here you can see the results for blood pressure variability in relation to cognitive function at last visit. The x-axis shows decile of systolic blood pressure variability. The y-axis is the mean of cognitive function in different domains. And it shows that, and again, these results are multivariate adjusted for basically for age, sex, race, education, and also vascular risk factors and diseases, including history of hypertension and history of stroke. So we can see that higher systolic blood pressure variability is associated with the worse performance in all domains of cognitive function at the end of a study, with all the associations having a p-value less than 0.001. Next slide, please. And finally, these are our results showing the relation between blood pressure variability and incident Alzheimer's disease and mild cognitive impairment. These are Kaplan-Meier curves. And the upper two curves shows the relation for incident Alzheimer's disease, and the lower two curves shows the relation with mild cognitive impairment. And you can see again that those in the highest tertile of both systolic and diastolic blood pressure variability had a higher risk for Alzheimer's disease and mild cognitive impairment. And the risk appears to be separating around 8 years of age for Alzheimer's disease, and for mild cognitive impairment around 4 years, after 4 years. Next slide, please. So, and then we did Cox proportional hazard models to adjust for risk factors. And after we did that, we found that higher systolic blood pressure variability was associated with 1.27-fold increased risk of Alzheimer's disease and 1.17-fold increased risk of mild cognitive impairment. But the diastolic blood pressure variability was only associated with 1.18-fold increased risk of mild cognitive impairment, but not with Alzheimer's disease after adjusting for risk factors and medication use. Next slide, please. So in summary, in this community-based cohort of individual more than 65 years of age, we show that higher visit-to-visit variability in blood pressure in older adults is associated with worse cognitive function after around 10 years. It is also associated with a steeper decline in cognitive function, but also importantly, higher variability in blood pressure is associated with increased risk of mild cognitive impairment and Alzheimer's disease. Next slide, please. Yes, and with this, I would like to conclude and thank my mentors, especially Dr. Gorelik and Dr. Soron, and also our collaborators at Rush Alzheimer's Disease Center, Dr. Bennett and Dr. Barnes. And thanks for your attention. I would be happy to receive questions.
Yes, thank you very much for a clear presentation. So I would like to start off with 2 questions I have. One is in terms of your study population. You had about 4,500 participants from the 3 cohorts. And then for the analysis, we have 2,500. So could you talk us through why you nearly drop out of 40%? Was it availability of the data, or were there other reasons? Or do you also
that's a good question, because yeah, so actually the include like the these cohorts, they aimed to include participants who didn't have any known dementia or at baseline, but after they enrolled at baseline, they went through evaluation, and when they ascertained the clinical diagnosis of dementia, actually it turned out that more than half of them had mild cognitive impairment or dementia. So we lost most of the population because of that, because we wanted to include cognitively normal participants.
Oh, okay, that's a surprisingly big number.
Yes, that's true.
Maybe half of them having MCI. Okay, so the second thing I was wondering, in one of your slides in which you showed the deciles of blood pressure variability, did you also suspect some sort of a U shape in your analysis? Because I know from the work Yuan Ma has been doing based on the Rotterdam study is that we did find U-shaped associations, meaning that large variations on both ends of the spectrum are related to dementia. So did you? I sense that there was some sort of U-shape in your data, but do you all explore that further?
No, we didn't specifically look into U-shaped or nonlinear associations in general, but it's a good point to look into that, because we know that the relation between blood pressure and cognitive outcomes in old age is a little bit controversial. And for blood pressure variability, yes, the Rotterdam study has shown that there seems to be the both end of blood pressure variability seems to be predicting or having a predictive impact on cognition. So yeah, that's a great point, and we will look into that. At least, I mean, the deciles, yeah, there seems to be a trend, but yeah, it worth exploring further.
Yeah, maybe combining a few subgroups instead of having two small groups might be worthwhile.
Yeah, okay.
Okay, perfect. Thank you.
Thanks
I don't see any other questions, so I guess we should carry on to the final presentation, and I will let Daniel take the lead here.
Yes, thank you very much, Kamran. And for the final presentation that will conclude this first symposium on vascular risk factors and heart variability for cognition and dementia, will be given by Dr. Rutirakuan. I hope I pronounced that correctly. If not, please let me know how it is done. And she will be talking about the risk of cardiovascular risk factor subgroups on Alzheimer's disease.
Thanks for that introduction. You actually pronounced my name quite well. So, and with that, yeah, so today I'll be speaking to you about a study we're conducting at Sunnybrook, investigating the risk of cardiovascular risk factor subgroups on Alzheimer's disease, a latent class approach. Next, please. As you all know, the cardiovascular disease has widespread impacts. It is not only highly prevalent, it is associated with brain injury, such as vascular dysfunction and AD-related neuropathology. It is also associated with poor outcomes, such as increased frailty, mortality, cognitive decline, as well as an increased risk of Alzheimer's disease. Next, please. However, most of the evidence to date looking at the link between cardiovascular risk factors and Alzheimer's disease or dementia are primarily focused on individual risk factors only. And we know in the elderly population, cardiovascular risk factors are often comorbid with one another. So investigating how these risk factors cluster and how these clusters may be associated with risks of Alzheimer's disease may be more representative of a real world population. Next, please. And that is what led to this study, using data collected from 12,412 cognitively normal individuals from the National Alzheimer's Coordinating Center data set. Our first objective was to identify clusters of cardiovascular risk factors in this participant group, I should say. And our second objective was to identify differences in the risk of Alzheimer's disease between groups. Next, please. And just to give you an idea of our study sample, they were about 71 years old, about 35% were male. They were highly educated, had high MMSE scores reflective of a population that had normal cognition. Hypertension was the most common cardiovascular risk factor, followed by hypercholesterolemia, smoking history, high BMI, heart-related conditions, diabetes, and finally stroke or TIA. About 27% had the presence of at least one E4 allele, 6% progressed to Alzheimer's disease, and the average duration of follow-up was about 65 months. Next. So for our first objective, we conducted a multi-level latent class analysis with the 7 cardiovascular risk factors indicated on the left panel here. And we conducted a latent class analysis with 1 to 6 classes. Next, please. Based on the statistical metrics, we selected a 3-class model. Our 3 classes included a reference group, which had low probabilities of cardiovascular risk factors. Our second group was, we labeled a vascular dominant group, because they had high probabilities of hypertension and hypercholesterolemia. And our third class, we labeled the vascular and metabolic group, because in addition to having high probabilities of hypertension and hypercholesterolemia, they also had metabolic risk factors such as high probability of diabetes, as well as high probabilities of high BMI. Next. To investigate differences between groups in the risk of AD, we used an approach, a 3-step analyze approach called the BCH method. This is more of a novel method that you can use with latent class analysis, and it takes into account classification errors that may occur when you do cluster-based analysis instead of simply extracting your classes and analyzing differences that way. Next. And just to give you an idea of demographic differences between groups, our vascular groups were significantly older, were very slightly less educated, had similar MMSE scores. There was more males in the vascular groups, and the vascular dominant group had a slightly lower percentage of an E4 allele compared to the reference group. Next. So with regards to the risk of AD between classes, what you can see is the incidence of AD was highest in the vascular dominant group, followed by the vascular metabolic group and the reference group. However, there are only significant differences between the vascular dominant group and the reference group. Next. So given those findings with Alzheimer's disease, admittedly, we did not expect a lack of finding with the vascular metabolic group. We decided to do a post hoc analysis with mortality given the association between cardiovascular risk factors and mortality as well. So what we did find was both the vascular dominant group and the vascular metabolic group had a higher incidences of death compared to the reference group. Next. And we also looked at the proportion of death in those who did not progress to AD, and the incidence of that was significantly greater in both the vascular groups compared to the reference group. And we also looked at the proportion of individuals who were alive throughout follow-up and who progressed to AD, and this was higher in both the vascular dominant and vascular metabolic group compared to the reference group. Next. And just to conclude and summarize, we identified 3 classes. The incidence of AD was greatest in the vascular dominant group, followed by the vascular metabolic group and the reference group. Our lack of findings with the vascular metabolic group might be due to selective mortality. We hope to further investigate biological differences between the classes, as well as the efficacy of cardiovascular medications, which will hopefully lead research and clinical-based decisions on risk stratification. We also hope to enlist other major data sets to confirm the reliability and generalizability of our model as well. Next. Just like to thank my co-authors here for their assistance with their work. And if I don't have time to answer questions, you can contact me at the email below. Thank you.
Thank you very much. I think we have time for 1 or 2 questions. I don't see at the moment a question in the chat, so in between I will ask a question. I really like the approach of creating those classes. However, what I found, and I may have missed it, but the history of cardiovascular disease, where was that categorized? In which of the classes did that pop up as a cardiovascular risk factor?
Oh, like how did we classify a cardiovascular risk? Okay, so yeah, sorry, due to time limits, I probably didn't go into that in detail, but
no worries.
Yeah, we use both clinical and clinical measurements as well as medication. So for hypertension, we used both a clinical assessment of it and if they used an antihypertensive medication, for example.
Right, so medication use was also included in the definition of the,
yeah.
Okay. I see that we have 1 minute left. I see one final question in the chat popping up. Is there any follow-up in the deceased with autopsy to certify the clinical diagnosis or of AD or mixed?
That is actually what we're working on right now. We do have access to postmortem data and whether these individuals are, I guess, true positive for clinically diagnosed AD, as well as mixed. So stay tuned for that.
Yes, that would be a very nice and very unique, I would say, also addition to the study. Very great work. And with that, I would like to give the word back to Kamran to close off the session.
Yeah, okay. I would like to thank all the speakers for very nice presentations. And I guess we're all familiar with vascular factors in dementia and cognition, but especially these cardiac biomarkers and markers of function are very interesting. And I guess a lot of work currently being done, but also for the future, I think we can look forward to very nice work in this area. So once again, thank you all the speakers for the great presentations and for the organizers for giving Daniel and me this opportunity to organize this symposium. And with that, I would like to close this session and give the word to Adrian Wong, who will be leading the next session, which is the first poster blitz session. So Adrian, up to you.